Very good morning to all of you. It's been 8 months since we have been battling with this COVID-19 pandemic, and till date, none of the pharmacological agents have been proven or have been shown to have conclusive effect or positive effect on the outcome of these patients. Amongst this first agent has been talked about by Professor R.K. Singh, that is the antiviral therapy. And one of the controversial topics, controversial agents, is glucocorticoids. And it won't be wrong to say that till date, the only agent, only pharmacological therapy which have been associated with the improvement in mortality, that is providing survival benefit, is corticosteroids. So I'll be presenting you the available evidence about glucocorticoids in COVID-19 and our approach, which we follow in PGI. About 15 to 20 patients of COVID-19 go on to develop ARDS, and it is linked to massive release of cytokines, and they further lead to organ failures and multi-organ failure syndrome. There are various risk factors for development of ARDS, such as older age, presence of an underlying immunocompromised state, neutrophilia, presence of other organ dysfunction and coagulation dysfunctions. And this all massive cytokine release leads to a situation called, have been differently named as cytokine release syndrome and SIRS, or secondary hemophagocytic lymphohistiocytosis. The management of this situation is the most controversial, and it's crucial also at the same time, that because the use of immunosuppressive drugs such as glucocorticoids, they definitely inhibit the tissue damage, but at the same time they curb the cell-mediated immunity and make the patient more vulnerable for secondary infection and various other complications. What SARS-CoV-2, that is coronavirus, does is to hamper with the normal alveolar ventilation and pulmonary blood flow, and after binding to the receptors leads to activation of immune cells, macrophage and monocytes, leading to massive release of cytokines and leading to alveolar flooding, diffuse alveolar damage, interstitial fibrosis, basement membrane thickening, interstitial inflammation, and endothelialitis, which leads to a state called thromboinflammation and leads to the consequences which happen because of the infection. Now, glucocorticoids, going by the mechanisms and the pathogenesis, glucocorticoids were thought to be that they will benefit in this situation, looking at the pathogenesis, because they have effects on the cell-mediated immunity. So the various mechanisms, as all of us know, for glucocorticoids is the genomic or non-genomic mechanisms, which acts to the transcription of inhibiting the transcription of genes and involved in the activation of leukocytes and reduction of pro-inflammatory cytokines, and decreasing the release of cytokines, regulating the function of macrophages, epithelial cells, lymphocyte activities, and also release of histamine from the basophil is also impaired. So, and non-genomic mechanism, which is very rapid, that is within minutes or seconds to binding to the glucocorticoid receptor, there is a inhibition of that lipoxygenase pathway, and leading to decreased release of arachidonic acids, prostaglandins, leukotrienes, and platelet activating factor. So these are the various mechanisms in which actually steroids exhibit their anti-inflammatory effect, which is the cornerstone of therapy in various inflammatory conditions, including infective and non-infective pathologies. So they were used. It was hypothesized that if they will be used in ARDS resulting from sepsis, or ARDS resulting from infective conditions, it may be beneficial. So actually, the impetus or the stimulus came from the studies which were done in sepsis and ARDS. So this is one meta-analysis which I performed in 2007, published in Respirology, before 2010, when the majority of trials done in sepsis ARDS, looking at the mortality of use of glucocorticoids in early and late ARDS. At that time, evidence did not support any role of corticosteroids in the management of ARDS, both in the early stages and in the late stages. However, after that, there was a lull for around 5 years, and people were reluctant to use corticosteroids in situations like this. But over the past 5 years, there are few RCTs which suggested some benefit of corticosteroids in ARDS. The Approaches trial was published, in which more than 1,200 patients were randomized to low-dose hydrocortisone plus fluorocortisone, and they have showed that there was a lower 90-day mortality in the hydrocortisone group. Similarly, the adrenal trial, which was a trial randomizing more than 3,500 patients with septic shock, and they were randomized to low-dose hydrocortisone versus placebo, and there was a shorter duration of mechanical ventilation and faster resolution of shock in hydrocortisone group. Similarly, in DEXA ARDS trial, which was a small trial of 277 patients with moderate to severe ARDS, they found that patient randomized to high-dose dexamethasone compared to routine care had lower 60 days all-cause mortality and more ventilator-free days. So there was some stimulus from these studies, and in the Cochrane meta-analysis, it was concluded that low-dose corticosteroids may be associated with reduced mortality in patients with sepsis and ARDS. However, a different view was put forward in another systematic review, but there is no beneficial effect of high-dose corticosteroids or low-dose corticosteroids in treatment of sepsis and ARDS. The conclusion of both the reviews emphasized that there is there is low certainty evidence in evaluation of these conditions, and there is a potential risk of bias, and there is inconsistency in the results. So clinical practice guidelines at that time gave only a very weak recommendation for the use of hydrocortisone in patients with septic shock after adequate fluid resuscitation, which we use routinely in the standard of care at present. So going by all this and the early observational data from China, which suggested some potential mortality benefit of corticosteroids in COVID-19, the Surviving Sepsis campaign for COVID-19, published in March 2020, gave a weak recommendation for the use of corticosteroids in patients with COVID-19 who required mechanical ventilation. However, conversely, the guidelines from IDSA, which were published in 2020, gave a negative recommendation for the use of corticosteroids. And this was also, associated, or this can, I can say, it was also compounded by the previous negative results in the previous epidemics like SARS and MERS, which were demonstrated in which there was a delayed viral clearance demonstrated in various studies, various case series. So overall, and also the experience from influenza pneumonia. So overall, there was reluctance in the use of corticosteroids till April 2020 or May 2020, and it was only used. We were limited to the various guidelines and the guidance from the Ministry of Health and Family Welfare and from other international agencies. Then came the recovery trial.
2 more minutes,
this is a very large randomized controlled trial, which enrolled more than 6,000 patients, and it was shown that treatment with dexamethasone reduced mortality by 1/3 in patient receiving mechanical ventilation and 1/5 by patient receiving supplemental oxygen. There was no benefit in patient not receiving any respiratory supports, and this led to updation of various guidelines, and they started giving a strong recommendation to the use of corticosteroids in patient receiving mechanical ventilation and receiving oxygen therapy with COVID-19. And all the trials which were going on were halted. Enrollment was halted, and this is what a large RCT impacts on the research. After that, there was publication of flurry of trials in JAMA, that is REMAP-CAP trial, which showed some modest benefit after a statistical analysis because it was underpowered. Similarly, a Codex trial was published in Brazil ICUs, which showed that 28-day mortality was not significant, but the ventilator-free days were better. It was also stopped prematurely. Then came the Metcovit trial, which was slightly negative, the use of negative results with the use of methylprednisolone. And they raised the questions about increased infections, hyperglycemia, and other metabolic complications with the use of corticosteroids. And the Cape COVID trial, this study was a double-blind trial in France, and they showed that hydrocortisone does not reduce treatment failure, defined as death or persistent respiratory support in ICU patients with COVID-19. This study was also terminated early, and it is difficult to make conclusions from all these trials because they were underpowered to draw any conclusion. And the meta-analysis of these studies by WHO REACT working group showed that 28-day mortality was lower in patient randomized to corticosteroids compared to, and there was little heterogeneity across this study. So there was criticism of these data that mortality benefit to dexamethasone was only 2.8% overall, and most of the patients were from the recovery. And mortality was measured at 28 days, despite the evidence that adverse impact of steroid administration in acute condition may be seen up to 90 days. And hyperglycemia, which was a common side effect of corticosteroids, is associated with poor outcomes. And despite having 25% of patients in recovery trial having diabetes, this subset was not separately analyzed. So, another fact is the ARDS with cytokine storm, that we know that several patients on standard dose of corticosteroids go on to deteriorate. And in this scenario, a small RCT of 68 patients was randomized to 250 milligram of methylprednisolone pulse, and the clinical improvement was higher in methylprednisolone group than in the standard group. So the use of high dose corticosteroids was also done in various case series and cohort studies, and also another trial which is going to be published in Lancet, which is slightly equivocal. So with this data, we have some unanswered questions that do the benefits of optimal dosing of corticosteroid different between different ARDS subphenotypes which have been talked about, and what is the optimal dosing duration of steroids with response to biomarkers such as CRP, ferritin, etc. And does the inflammation rebound after cessation of corticosteroids? Should less severely or ill non-hospitalized patient be treated with corticosteroids? Or do corticosteroids delay the clearance of the virus? And if so, what is the clinical impact of that? So with this background, we continued. Just a minute, sir. Now, summarizing our experience from one of the ICUs, we pulled around records of 250 consecutive patients admitted to ICU, and we found that in moderate category, the patient was receiving dexamethasone in the dose of 1.1 milligram per kg per day. Mortality was 5.1%. However, in 200 patients in moderate to severe category, the patients either received dexamethasone 0.2 milligram per kg or 1 to 2 milligram per kg of methylprednisolone, and the mortality was similar in both the groups. And in the subgroup analysis, those patients who continued to deteriorate on standard dose corticosteroids, they were given pulse methylprednisolone, and intubation and mechanical ventilation was avoided in 23 out of these patients, and they were discharged from the ICU. Mortality was 45%. So the practical considerations is that when we should use corticosteroid not exceeding 0.1 to 0.2 milligram per kg of dexamethasone. Decision to use higher dose glucocorticoid should be individualized, weighing the risk and benefits. And for the patient with milder disease, elderly population, and individual diabetes, the absence of longer-term follow-up makes the routine use of corticosteroids still questionable in view of concerns raised by other investigators. So we need to deploy decision-making models with different phenotypes of ARDS, and with the available biomarkers, that is CRP, ferritin, and or interleukin-6. So, and high-dose corticosteroids may be justified with or without targeted therapy in patients with rapid deterioration with impending mechanical ventilation. So our approach is that A patient with COVID-19 pneumonia comes. If he's non-hypoxic, there is no glucocorticoid administration. If the patient is hypoxic with moderate illness, we give dexamethasone in the dose of 0.1 or 0.2 milligram per kg per day for 7 to 10 days. However, if the patient has severe illness and markedly raised inflammatory markers and CT severity score of more than 15, we use methylprednisolone in 1 to 2 milligram per kg body weight for 7 to 10 days and taper it over 2 to 4 weeks to 6 weeks, depending on radiological recovery and clinical recovery. However, if the patient continues to deteriorate on this therapy, then we consider high dose methylprednisolone in the dose of 250 to 500 milligram per day, learning from the previous experiences and the previous data published, and with or without IL-6 as a rescue measure. So this is all about glucocorticoids in COVID-19. Thank you very much.